Right, oeddech chi'n gallu'n clywed I nawr?
Heledd Gilbride, right negus.
So one person's put a notice up saying that they can't hear me, but I don't, yes, I don't know whether they can hear me now or not.
Yes.
Okay, brilliant. Sorry I chi gyd. So we just wedi bod yn adrodd y cwpl ystadegau cyffredinol I ddechrau da. A nawr, o'n I jyst yn sôn yn byty y ffeithiau yma sydd wedi cael ei adrodd o rhan derbyn, o diffyg derbyn gofal yn y mamiaeth y claf. Felly, mae diffyg derbyn gofal yn y mamiaeth yn gallu fod yn gamarweiniol o rhan diagnosis, a mae fe'n gallu atal triniaeth effeithiol ac o'r safon orau i'r claf. Mae fe hefyd yn gallu golygu bod cleifion falle ddim yn hollol ymwybodol o triniaeth maen nhw'n mynd I gael, ac felly mae cwestiwn mawr yn bwyty y cydsyniad gwybodus. Mae yna nifer o bobl hefyd sydd yn agored I niwed o ddim derbyn gofal yn eu mamiaeth gan gynnwys plant, pobl oedrannus, pobl sydd gyda chyflyrau niwroddirywiol a pobl sydd gyda chyflyrau iechyd meddwl. Ond mae yna nifer o bobl ymhlith y boblogaeth gyffredinol hefyd falle sydd ddim yn sylweddoli'r effaith o hyn. Mae yna straen clinigol ble enghraifft yn ystod dymweiniau, menywod yn rhoi genedigaeth, pobl yn dod mewn y mas o anesthetic, ble dyw pobl ddim yn sylweddoli, maen nhw'n debygol iawn o referto nôl i'w mamiaeth nhw yn ystod y sefyllfaoedd hynny. Ac felly mae'n falle byth peryglus os nag yn nhw'n sylweddoli hyn. Yn wedig os mae problem I gael o ran cyfathrebu yn y dyfodol. Nawr, ni fel clinigwyr, falle, ti'n bach fwy ymwybodol o hyn, ond mae yna diffyg llenyddiaeth sydd wedi cael ei cyhoeddi ar yr effaith biolegol o hyn. Nawr, nes I ddechrau ar y trywydd yn ymchwil o ran y Gymraeg yn gofal iechyd nôl y 2021 gyda un o'n myfyrwyr sy'n ma heddi, fel mae'n digwydd, Maisie, mae'n cyflwyno poster, a cwpl o flynyddoedd yn ôl o'n i'n trafod I phrosiect trydydd blwyddyn ac oedd hi am edrych ar y barn ac ymwybyddiaeth y cyhoedd o ran gofal iechyd dwyieithog yng Nghymru. Nawr ar y pryd y dim profiad fi yn y maes, felly eithon ni ati I drafod y pwnc yn fwy manwl gyda pobl eraill, gyda Dr Llinus Roberts, oedd yn feddyg teulu eisiau gyfyrddin, a Gwerfyl Roberts hefyd oedd yn nyrs ac yn gwneud y peth ymchwil yn y Prifysgol Bangor. Wnaethon ni hefyd siarad gyda un o swyddogion Comisiynydd y Gymraeg, ble daethon ni I ddeall bod ddim mor gallu gyda ni I hawlio gofal dwyieithog yn sefydleuoedd preifat, a nath hwnnw cymryd ni, wel, o'n i'n synnu braidd at hwnnw. Ond oherwydd y rheswm am ni oedd bod y sefydliadau preifat, y meddygfeydd teuluol, yr optegydd, y deintydd, dyn nhw ddim yn dod yn uniongyrchol a dan safonau'r Gymraeg. Ac felly o'n i'n teimlo bod e'n bwysig iawn I ni cael beth yn gwmws o'r profiadau'r cyhoedd a ran dwyieithrwydd wrth bod nhw'n cyrchu gofal iechyd. Okay, so fi'n mynd I sôn am cwpl o brosiectau o fewn y cyflwyniad yma, so yr un fwy'n I siarad am bwyty fwyaf yw'r holiadur wnaethon ni rhoi mas i'r boblogaeth gyffredinol oedd yn edrych ar ymwybyddiaeth a barn y cyhoedd ar gofal dwyieithog. Ac wedyn ni, nath Maisie, pan oedd hi'n gwneud gradd meistr da fi, nath hi rhoi holiadur mas wedyn ni oedd yn edrych yn fwy penodol ar bobl oedd gyda chyflyrau cronig a'r Gymraeg yn eu gofal nhw. I ni hefyd wedi rhoi holiadur mas I cleifion sydd yn mynd at yr optegydd ac hefyd wedi casglu barn optegwyr yn ogystal â'r gofalwyr iechyd cyffredinol. Nawr, yn amlwg, cyn rhoi holiaduron mas y cyhoedd, mae'n rhoi cais moeseg I mewn fel y Brifysgol, ac wrth cynllunio'r holiadur I ddechrau da, mae eisiau sicrhau bod ni'n ymwybodol o beth yn gwmws yw'r llenyddiaeth sydd wedi cael ei cyhoeddi. Felly, ar ôl I ni llunio holiadur, ni wedi trafod yr holiadur hyn mewn grwpiau ffocws I gael sicrhau bod y cyd-destun yn iawn a bod ni'n gallu cael yr atebion, falle, atebion fwy o dwfwn posib mas o'r cyhoedd I cael sicrhau bod ni'n cael y gorau posib mas o'r ymatebion. Ni'n adeiladu'n holiaduron ni drwy ddefnyddio system meddalwedd o'r enw Qualtrics, a mae hwnnw'n eitha effeithiol. Ac wedyn ni wrth bod ni'n paratoi'r data, glanhau, ni'n defnyddio ystadegydd wedyn ni cael sicrhau bod ni'n dadansoddi fe i gyd yn iawn. Felly mae'r holiadur eu hunain wedi cael eu seilio ar y llenyddiaeth, a'r grwpiau ffocws, a wedyn ni mae'r holiadur sydd yn mynd mas at y darparwyr gofal iechyd wedi i rhannol i seilio ar y holiadur ni wedi wneud yn barod ar gyfer y cyhoedd, ond hefyd ar holiadur sydd yn mynd o'r Llywodraeth Cymru at y meddygfeydd teuluol bob blwyddyn hefyd i cael monitro i cynnydd o ran y Gymraeg. Yn math o grwpiau ffocws, wnaethon ni cynnal dath nifer o themau sydd yn eitha cyffredin, siarad ambyti llythrennedd iechyd, dynioliaeth, cydymffurfiaeth meddygaeth, yr elfen hyn o barch, ble mae pobl yn teimlo bod y meddygfeydd yn dangos parch atyn nhw pan mae pobl jyst yn dweud bore da. Hefyd, oedd tipyn o trafodaeth yn byti byth yn gwmws yw blaenoriaeth y claf, a bod yna deimlad weithiau bod angen aberthu dewis iaith mwyn cael cyrchu gofal iechyd falle yn fwy cyflym. Neu ar rhai o'r degau efo rhai mewn fwy safonol. Felly, yn gyfan gwbl, oedd y holiadur hyn yn benodol yn edrych ar casglu gwybodaeth am barn a phrofiadau siaradwyr Cymraeg, edrych ar eu ymwybyddiaeth nhw o'r diffyg hawl yn atfynediad at iechyd dwyieithog, ac wedyn ni hefyd edrych ar barn ac agweddau barn ar agweddau llafar ac ysgrifenedig y cleifion hyn ar eu gofal nhw. Nawr, yn gyfan gwbl, gaethon ni ryw 360 o ymatebwyr ar ôl glanhau'r data, a gaethon ni ymatebion o bob sir yng Nghymru, ac yn eitha cynnar wnaethon ni sylweddoli bod yna tueddiad yr ymatebion i newid falle yn ôl pa sir oedd pobl yn dod o. Felly, fe wnaethon ni dadansoddi'r data yn llawn fel oedd e wedi dod, ond hefyd edrych yn fwy penodol ar ymatebion oedd yn dod o'r siaradwyr oedd yn dod o ardaloedd ble mae dros 35% o siaradwyr yn siarad Cymraeg, neu mae llai na 35% o'r boblogaeth, 35% o'r boblogaeth yn siarad Cymraeg. A pam eithon ni at y ffigwr na, wel, oedd na beth o'n i'n teimlo oedd yn doriad eitha naturiol rhwng y ddau fathau o siroedd ble mae'r poblogaethau yma. Mae yna ffurf eraill yn amlwg o ddadansoddi data, enghraifft gallen ni fod wedi mynd â nifer y siaradwyr fesul sir yn lleni, fel enghraifft mae rhywbeth fel 96,000 o siaradwyr Cymraeg yn Sir Gyfyrddin, tra bod rhywbeth fel 76,000 i gael yn Gaerdydd, ond yn amlwg yn Gaerdydd mae hwnna nifer fwy o siaradwyr fesul y lleoliad. Ond penderfynon ni i ddadansoddi'r data y ffordd hyn. Right. So, oedd nifer o blycau testun rhydd i gael dyn ni yn ystod yr holiadur, ac oedd nifer o'r themau yn dod mas o'r rheini yn eitha tebyg i beth dath mas o'r grwpiau ffocws. Ac yn ôl te pob tegwch i bobl, wnaethon nhw gwario lot o amser yn rhoi sylwadau. Yn amlwg yn bwnc oedd pobl yn teimlo'n eitha angerddol yn bwyty. Eto'r elfen hyn o barch, bod y teimladau o gysur yn fwy effeithiol yn y famiau, bod eisiau gofal ar gyfer pobl bregus, megis oedd hanner o'r testunau yn bwyty plant, eto bwyty pobl oedrannus, a wedyn ni o'r sylwadau eraill yn bwyty pobl gyda chyflyrau niwroddirwyol, pobl oedd yn mynd trwyddo genedigaeth, a y pobl oedd gyda cyflyrau iechyd meddwl. Oedd na hefyd y teimlad yma bod pobl yn deall y sefyllfa, yr pwysau enfawr sydd ar y gig ar hyn o bryd, a falle yn bod ni ddim am ofyn am y gwasanaethau ddwyieithog, oherwydd bod ni ddim moyn ychwanegu at y faith yna. Mae'r gyfalwyr iechyd yn mynd trwyddo yn barod. Cwpl o ystadegau i chi o'r holiadur. So, wnaethon ni edrych ar asesu ymwybyddiaeth y cyhoedd o'r diffyg mynediad at gofal iechyd ddwyieithog. A dim ond 27% o'r ymatebwyr oedd yn sylweddoli bod angen i'r ysbytau i gwrdd o safonau Cymraeg, ond bod dim rhaid i'r meddygfeydd teulu. Ac oedd 47% o'r ymatebwyr yn teimlo bod eu angen nhw i ddefnyddio'r Gymraeg ddim yn cael ei gymru o ddifri. Ac oedd hwn yn un wnaethon ni dadansoddi fesul sir, ac oedd hwn yn ymrywio o 39% y siroedd ble mae fwy o siaradwyr Cymraeg i gymharu a 52% o'r boblogaeth ble mae llai o'r Gymraeg. Felly, yn amlwg, mae pobl sydd dod o falle sydd Powys, ble mae llai o siaradwyr Cymraeg yn gyffredinol, maen nhw dal i fod yn teimlo'n angerddol iawn bod yn bwyty i Cymraeg nhw a'i hawl nhw i ddefnyddio'r iaith. Wedyn wnaethon ni hefyd asesu barn pobl ar agweddau llafar i gofal. Ac roedd 73% yn gyffredinol yn teimlo bod y Gymraeg yn chwarae rhan bwysig neu pwysig iawn o'i gofal. Ac nath hwnnw ymrywio o 89% yn y siroedd neu ble mae dros 35% yn siarad Cymraeg i 61% o'r siroedd yn y siroedd ble mae llai o'r Gymraeg. Ac beth sydd falle yn eitha trist yw bod 71% o ymatebwyr eriod wedi cael cynnig i ddefnyddio'r Gymraeg mewn ymgymhoriadau. A nath hwnna newid i 60% yn y siroedd ble mae mwy o Gymraeg, sydd falle tyma bach yn surprising. Ond falle sydd ddim yn cymaint o surprise yw bod 81% o'r pobl ble mae llai sy'n byw yn ardaloedd ble mae llai o Gymraeg eriod wedi cael y cynnig hwnnw. Nawr, wnaethon ni edrych yn benodol ar yr ymatebwyr oedd gyda GP Saesneg. Ac wnaethon ni gofyn rheini os bydden nhw wedi teimlo yn fwy cyfforddus betaw nhw wedi i cael i ymgymhoriadau ddwyieithog, ac fe nath 76% yn gyffredinol ddweud bydden nhw wedi teimlo yn fwy cyfforddus pe bydden nhw wedi cael yr ymgymhoriadau yna yn Gymraeg neu yn ddwyieithog, a nath hwnnw ymrywio o 76% yn ardaloedd mwy Gymraeg i 42% i'r ardaloedd ble mae llai o Gymraeg. Ac wedyn o'n i'n trial gofyn iddyn nhw ambwyty yr effaith yr iaith yn nhw eu hunain nhw. Ac nath 32% ddweud i bod o'r bobl oedd yn dod o'r ardaloedd ble mae'n fwy o Cymraeg, dweud bod nhw wedi cael eu cyfyngu gan yr anallu hyn i allu cyfathrebu yn ddwyieithog. Ac yn teimlo bod hwnnw yn rhywbeth sydd yn perthyn rhywfaint y cwestiwn o dan ni yn ein holiadur i bobl ath mas i cyflyrau cronig, ble nath 50% ddweud bod nhw wedi cael trafferth i meddwl am geiriau i egluro pethau yn y Saesneg. A beth mae hwn yn awgrymu i fi falle yw bod pobl falle sydd yn tueddu mynd at GP neu gweld tîm clinigol yn fwy aml, bod nhw falle yn dod yn fwy self-aware o'r falle y broblem hyn sydd gyda nhw i ddim allu siarad yn Saesneg mewn sefyllfa fel 'na. Sydd falle hefyd yn gwneud yn fwy dansierus os o'n i'n meddwl bod pobl yn y boblogaeth gyffredinol sydd yn meddwl i bod nhw'n hollol ddwyieithog a ddim yn sylweddoli shwt gall y straen clinigol hyn hela nhw i referto nôl i'w mamiaeth nhw. Wnaethon ni hefyd gofyn yn y rholiadur hyn os bydde pobl yn hapus i rhoi i dewis iaith nhw ar eu cyfnodion meddygol. Ac dim ond un person nath ymateb i'r rholiadur dweud bydden nhw ddim yn hapus gyda ni, so 0.3% o'r ymatebwyr. Felly, petai meddygfeydd teuluol yn dechrau cofnodi hyn ar cyfnodion iechyd pobl, ni fydde llawer o wrthwynebiad. So nawr fi'n mynd i dangos cwpl o sylwadau i chi sydd wedi dod o'r rhai holiaduron eraill ni. A mae rhain yn sylwadau sydd wedi dod o'r holiadur ath mas i'r cleifion sydd wedi ymweld gyda'r optegydd. Mae'r sylwadau hyn yn dod o optegwyr, ac mae'r sylwadau hyn am yr anawsterau ieithyddol maen nhw wedi dod ar eu traws. Nawr, pan ni'n rhoi holiaduron fel hyn mas, y pobl sy'n tueddu gadael sylwadau yw pobl sy'n teimlo'n naill ai yn angerddol o ran bod yn bositif iawn neu negyddol iawn yn bwyty'r pwnc, a dyw'r holiadur hyn ddim wedi bod yn wahanol o gwbl o ran ni. Felly, wnaethon ni i dod ar draws nifer o sylwadau yn dweud, bod optegwyr y Cymraeg a Saesneg o ran y iaith nhw wedi gweld yr anawsterau iaith hyn, a maen nhw wedi deall y broblem, maen nhw wedi cael mewnwelediad mewn iddo fe. A hefyd maen nhw'n trial wneud rhywbeth y bwyty fe, maen nhw moyn dysgu cwpl o eiriau i cael galluogi'r cyfathrebiad gwell na gyda cleifion. Ond ni hefyd wedi dod ar draws nifer y sylwadau optegwyr eraill, falle sydd ddim wirioneddol wedi deall beth o gwmws yw patient-centred care, a bod nhw ddim yn credu bod unrhyw broblem o gwbl gyda wneud i asesiadau nhw i gyd drwy gyfrwng y Saesneg, achos bod ni siaradwyr Cymraeg yn amlwg yn hollol ddwyieithog wedi'r cwbl. A dyma rhai sylwadau nawr dath o'r optegwyr yn bwyty'r cynnig rhagweithiol. Eto, mae yna rhai sydd oedd yn bositif, ond rwy bwrpasol wedi cynnwys nifer o rhai negyddol i chi cael gweld barn cryf sydd i gael o fewn y maes. Nawr, fel ymchwilydd, i ni fod aros yn ddi-bias, ond gan taw bwriad ein holiaduron yw i cael trial casglu tystiolaeth am pam ni angen y cynnig rhagweithiol, ond ni'n teimlo bod rhai o'r sylwadau hyn yn peri risg i gofal cleifion. Ac felly ni wedi rhannu nhw gyda Shared Services yn y GIG a gyda RHCW a Llywodraeth Cymru i cael gweld sut gallwn ni mynd ymlaen a sicrhau bod y gweithlu dyfodol a presennol yn ymwybodol bod yna ddwy iaith yng Nghymru, bod angen gofal ddwyieithog ar cleifion Cymru, a y ffordd gorau i ofalu a bobl dwyieithog yw i cael rhoi'r cynnig rhagweithiol yna iddyn nhw. So mae hwn jyst yn sôn am cwpl o prosiectau eraill i ni wedi dechrau. Mae holiadur mas dyn ni to sydd yn edrych ar profiadau'r cyhoedd o ran y Gymraeg a gofal diwedd oes a galar a sut mae hwnna wedi wario, sut mae'r Gymraeg wedi wario rôl yn falle'n helpu nhw yn ei galar. I ni'n edrych hefyd ar pa wasanaethau galar sydd ar gael yn Nghymru, hefyd yn enwedig o ran dwyieithog. Ac hefyd, mae holiadur mas yn hyn o bryd sydd yn edrych ar pa termau mae pobl sydd â diabetes yn ffindo'n stigmateiddio. A'r pwrpas hwnna yw i cael galluogi y cyhoeddiad o Language Matters Diabetes yn y cyd-destun Gymraeg, achos mae hwnnw ar hyn o bryd yn aros i ni cael ffindo mas beth yw'r poblogaeth Cymraeg yn ffindo'n stigmateiddio, achos falle bod yn wahanol i'r astudiaeth Saesneg. Nawr, un prosiect mae'n teimlo'n eitha angerddol yn bwyty ar hyn o bryd yw, mae Maisie da fi wneud PhD nawr, so wedi bod â fi ers bod yn israddedig, wedi wneud gradd meistr yna, mae'n dechrau PhD, a mae hi'n mynd i edrych ar y dangosyddion biolegol, y biological indicators o pobl sydd gyda cyflyrau hir dymor, cyflyrau chronig, i cael gweld os mae'n y gwaniaeth, os mae'n dechrau siaradwyr Cymraeg, a maen nhw'n cael gofal yn y Saesneg neu gofal yn y Gymraeg, a sut maen nhw'n gallu rheoleiddio i cyflyrau nhw dros amser. So, falle fydd e ddim yn dangos bod unrhyw gwahaniaeth o gwbl, ond os nag ni'n edrych nawn ni ddim yn gwybod. Wedyn ni, mae pobl fi'n gweithio gyda mas yn Gwlad y Basg hefyd, a'r gobeith yw bod ni'n rhannu nifer o'r astudiaethau yma o'r holiaduron hyn gyda'r boblogaeth Basgaidd, fel bod ni'n gallu gwneud rhyw fath o cymhariaeth o ran y poblogaethau. Nawr, ble mae Gwlad y Basg? Wel, mae fe'n wlad fach sydd rhwng Sbaen a Ffrainc. Nawr, y iaith dominyddol yw Sbaeneg yn fan hyn, a'r iaith lleiafrifol yw Basgeg neu Iwsgara. A rhain gydweithwyr i mas fan ni, sef Dr John Zarate Sesma a Dr Aitor Montes Lazar. A mae'r ddoi hyn wedi bod yn ganolog i cael gwthio deddfe trwyddo ran wneud yr ymchwil a siarad yn bwyty'r cynnig rhagweithiol a sicrhau bod prosesau newydd yn cael eu cyflwyno i'r prosesau gofal iechyd. Nawr, maen nhw wedi llwyddo i cael y cynnig rhagweithiol yma i fod yn bresennol yn eu gwlad nhw. Ac un peth da maen nhw wedi, wel, un peth maen nhw wedi cyflwyno yw'r ffaith os mae clinigwr nawr yn derbyn nodiadau claf yn Basgedd, dyn nhw ddim cael gofyn amdanyn nhw, mynd nôl at y GP a gofyn amdanyn nhw. Yn Sbaeneg, mae rhaid i nhw sorto fe hunain. Naill mae rhaid i nhw ffindo cyfieithydd eu hunain, neu maen nhw gorfod dysgu iwsgara. A fel la maen nhw wedi gwthio pethau fel un. A dyn nhw ddim yn cael achwyn yn byty'r peth. Maen nhw gorfod delio gyda fe. A wedyn ni, o ran yn goblygiadau ni, wel, o ran fel Prifysgol Abertawe ac fel ni fel ymchwilwyr, i ni'n gwbl tu ôl strategaeth mwy na geiriau Llywodraeth Cymru sydd yn edrych at meithrin mwy o falwyr dwyieithog yng Nghymru, fe bod ni'n gallu rhoi'r cynnig rhagweithiol na mas y boblogaeth. Ac felly ni yn bwydo'n ymchwil ni at Llywodraeth Cymru ac RHCW i gael sicrhau bod dan o'r dystiolaeth maen nhw angen i cael trial helpu pwysio deddfe a prosesau trwyddo. Yn wedi o ran y gweithlu, mae RHCW gyda nifer, maen nhw'n gyfrifol am y gweithlu sydd yn datblygu, ond hefyd nifer o'r CPD activities ar gyfer y gweithlu sydd mas yn barod yn gweithio. Felly fi'n gobeithio bydd nhw'n gallu helpu codi ymwybyddiaeth ar angen am gofal ddwyieithog yng Nghymru. Diolch yn fawr. Unrhyw gwestiwn?
Okay, thank you very much for having that. Any questions in the room? No? I don't think we've got any online questions. I haven't seen any popping up. Okay.
Diolch yn fawr i chi wrando.
Thank you very much. If there's no questions, please head back to the main building, and I think it's lunchtime, so enjoy your lunch.
Right, I'll make a start. So hopefully, if anyone can't hear me, just yeah, put your hand up on that. And Karen Ditcoat, my colleague, is on as well, so she's going to look at the chat and have a look to see if there's any questions, and also sort out if there's any technical issues with my slides, hopefully, so she can share as well. So thanks for coming. Oh, there's some more people. Hi. So thanks for coming to the presentation today. Hope you've had a good conference so far. My name's Louisa Morris. I'm a GP and I work in Hywel Dda. So one of my roles is Senior Clinical Editor for the Health Pathways team, which I've been doing since January 23, just nearly 2 years. And I don't have a national remit in the Health Pathways team. So this talk is really from a Hywel Dda perspective and how it helps us in Hywel Dda. So I'm going to share some slides. Hello, there's more people joining now. I'll stop talking for a sec. Yeah, so I'm Louisa Morris, GP on the Health Pathways team in Hywel Dda. My colleague Karen is here. You've got Nia on the programme as presenting, but unfortunately she's had a family commitment. She's had to rush off, so you've just got me for today. So I'm going to run you through some slides. If you want to ask any questions, please do so in the chat, and Karen will keep an eye on that. And we'll have time for questions at the end as well. So I'm going to share. Karen, if you can just tell me when you see it. How's that?
We can see it, but not in presenter mode. Can you view as a slide? That's it. Yep.
Yeah,
all good.
There's a bit of a delay there. Yeah, so yeah, just Louisa, no Nia, sorry. So for those of you who haven't heard of Community Health Pathways, it's an online tool. It's designed to be used by clinicians at the point of care, and it's designed to be used by primary care clinicians, although it can be quite handy working in secondary care as well. It outlines the point of the point of management from when the patient presents to primary care up until the point of referral should they need it. So what happens in secondary care isn't covered by the remit of Community Health Pathways. However, there is a separate system called Hospital Health Pathways, which deals with the secondary care elements, and that is being trialled in Cardiff currently. So Cardiff and Vale were the first people to develop Community Health Pathways in Wales. and it's a programme that came from New Zealand. So it's very common in New Zealand and Australia, and there's some places in England using it, and ideally all of Wales will be using it at some stage. So it'll support informed referral decisions across your local systems. Now, each pathway will be developed by the local GP clinical editor and a subject matter expert. So that subject matter expert may not be in your health board, because each pathway that we design is done initially from a national lens, a Welsh lens, and then localised for our local health board website. So each health board, apart from Betsy and Powys at the moment, have got this system live. So what are the benefits then? So it does form a bit of an online textbook. It's got essentially what's on NICE guidance, BNF, MHRA regs, all these things are drawn together into one place, so people don't have to keep clicking on external sources to have the most recent evidence in front of them. It's used at the point of care, and it will really give you information that will meet your own patient's needs, including how to organise third sector support, potentially community services and secondary care services in your locality. It does reflect whole system working, because they're developed between primary and secondary and community care experts. And the site itself can be accessed 24/7 on your desktop in work, or on your mobile device or iPad. So it is an external website, so it's quite handy for out of hours GPs on home visits, for example, who may not have a desktop. The platform supports equity of health delivery. So when we write the pathways, we do have to consider patient equity when doing that, and that it also aims to reduce variation, equity of care across regions, and that includes obviously rural regions where we may not have the same services as they do in inner cities. So from an education perspective, which is the focus of this session, we use the platform to alert healthcare professionals to the latest guidance. So if there's any changes in guidance, we will post these on our homepage, and I will show you that in a moment. Local processes may change. For example, when we had COVID, we had new guidance disseminated every day by email. So those things would come up as an alert. And we're using these pathways we're getting better at doing this. The more pathways we get live, to form the basis of educational sessions. So, for example, the GPs in Hywel Dda have a Wednesday lunchtime webinar, and the urologist last week was talking about scrotal pain, and he used the pathway as the basis for that educational session. So hopefully we're all singing off the same hymn sheet, and we're using this common platform for dissemination of knowledge and collaboration and learning. Feedback. We have got a feedback button on every single pathway, and that hopefully encourages continuous improvement. So if you're aware that a service has changed in your region and nobody's told the pathways team, then you can do that through the feedback button, or if there's any other suggestions for change. So it allows everyone to engage with the platform. Just a note on Welsh pathway sharing, because it's quite important. When Cardiff started this about 6 years ago, they actually designed the platform for Cardiff, and the initial plan was that every health board would start from scratch and do their own platform. So it was recognised that that caused quite a lot of work for every single health board, having to review every single pathway a minimum of every 3 years. And also everyone would have to start the pathways from scratch. So what was decided was that these pathways would be divided up amongst Wales. So each health board having their share of pathways to lead on. And we develop it, as I said, through an all Wales lens. And once it's agreed that that's sort of the gold standard, how we want things done in Wales, elements of that pathway can then be tweaked or localised to suit individual health boards, because obviously we can't all do things exactly the same way, but there shouldn't be unwarranted variation. And it is quite a good way of identifying where there may be unwarranted variation if we've got one outlier region, for example. The prioritisation, which pathways came first. Some of these were identified by the health boards as a need. Some were identified by the clinical implementation networks. And some were just high priority pathways because of long waiting lists. So, for example, things like hip arthritis, knee arthritis, long waiting list, lots of people waiting. So those pathways were prioritised. So fair sharing, every health board should benefit from this arrangement. And I've already mentioned unwarranted variation, but we do allow for local variation where needed. So I was just going to show you our website. So if I click on the link, are we seeing our website, Karen?
Yep.
Yeah, okay. So this is the list of pathways that Hywel Dda at the moment has localised. So we haven't localised all the pathways that have been taken live on the Welsh site, but these are the ones that we have. So some of these will be referral pages, like how do you get advice from urology, and some of them will be clinical pathways such as urinary incontinence in men. So if I go back to our homepage, so you can see this is where we put alerts on. So this is a recent one on mpox, so it's obvious there for you to see. We have our latest news in a list on the front page. And every time we put a new pathway on or amend a pathway, say, for example, NICE guidance changes and we change a pathway, it will come up there in the updates. We've tried to think of all the things that GPs or people in primary care use the most. And these are some of the links that we've included on our website. Now, some of these, obviously, SharePoint won't work unless you're on an NHS computer, but most of them will work on your mobile phone. And bringing in those patient programs such as, EPP. So trying to think outside, refer to secondary care. What else can the patient be offered in the community? The menu you see here on the left, you can find your pathways down there. So if you go under medicine, cardiology, these are all the cardiology pathways. The ones that are in grey is because we haven't localised them yet, and some of these we'd never localise because they're not that relevant to us, but hopefully the majority we will at some stage. I'm just going to click on palpitations randomly to just show you how the pathways are designed. So at the top, they're all written in the same way, and you can see when it was last reviewed, if it's current, if it's recent. And you can see any references that have been used. So at the top, we always have red flags, things that you don't want to miss. Then they've always got a background section, or usually got a background section that can give you a little bit more detail about the condition. Then it goes into assessment. So this will advise the clinician what they should be doing to assess patient, history, examination, investigation. So you'll get used to the way it's laid out the more you use it. And you may not need this bit. You might just want to jump straight on to management and see where you refer them. So, for example, in investigations, it says an ECG must be included with any cardiology referral. And then it will give you a bit more information about ECGs. Where we use the words must and consider, the LMC does look at these pathways, and if there's things that GPs shouldn't be doing or the primary care aren't funded for, then we have to be quite careful that we don't mandate it in the pathway. But some, consider is quite a good word, because there may be some practices that offer things like coil fitting, others don't. So in the management section, you've usually got emergency information at the top. And there's a problem at the moment with phoning 999 and getting a timely ambulance. So this was a change that was made the application of the GP indemnity scheme where there are ambulance delays in the community. So this is a real world problem now. And when it previously said 4999, some of our GPs fed back and said, well, I do 4999, but then I'm told there'll be a 7-hour wait. So we advise the patient to go in the car. But where does that leave me medical legally? So we've listened to that and amended the pathways to give more pragmatic advice here. And, you know, it just says essentially, if you can't get an ambulance, you need to document in the notes why you made the decision not to. So just little hints and tips like that. I'll skip past the rest of the clinical information just to show you the request section. So where it asks you to request a secondary care referral, it will either be same day or routine or urgent. When you click into this bit, this will take you to a Hywel Dda specific page. This will tell you how you access that referral in every county and what services are available. Now, this one is quite a complicated one because we have SDEC, which will take certain things and not others. And every SDEC in every county has a slightly different criteria. So this is a very long request page, which does spell out to you what we can and can't see in SDEC. And then for anyone you want to admit who's not suitable for SDEC, it will tell you to phone the medical reg on call usually. If I take you to a routine assessment, it tells you what criteria are seen urgently, what criteria are seen routinely. But this one doesn't actually. It doesn't split them into urgent or routine, but some pages do. And it will, under the provider, tell you if the speciality accepts electronic referrals or not. So for some of our community services, like pelvic health physio, they won't accept electronic referrals. They'll have a request page there instead. Right. I'm hoping if I come out of this, right, I'm back onto my presentation on my screen. So hopefully I am on yours as well.
Yes,
So
you are.
just a bit about where we are. So we went live in Hywel Dda in December 23. And to date, we've got 120-ish live pathways. These numbers change every day, and about 150 local request pages. We've had 17,000 views to date. And as you can see, we've got quite a lot of pathways in the draft phase as well. So we're aiming for at least 300 pathways by the end of the first 3 years of the programme, which is what the current Welsh Government funding is for, 3 years. Sorry, I'm trying to click on and nothing's happening. There we are. Right, so how to make the most of them then? So this content outlines our Hywel Dda management. So it's obviously more relevant to us. It may be relevant for Powys as well in terms of patients being referred into Hywel Dda. So some pathways will be, some won't be. It has got request and referral information specific to our location. And I didn't show you actually, I meant to, but at the end of the pathway, there's patient information resources and professional information resources. So in those patient and professional information resources, you may have educational sessions linked in there if you've identified any useful things. And there'll also be patient information leaflets and so on, or things like drug alerts that you may need to be aware of, just to highlight those. We've got the feedback button on every page, which we talked about. And our homepage, we've already seen that. So we ask our colleagues when we present this as much as we can to colleagues in Hywel Dda. We ask for feedback on pathways that would be of interest or a priority, but we also look at how many clicks we get on pathways. So if we're getting a lot of clicks on an unlocalized pathway that we haven't done yet, then we know that people want that pathway, so that leads us to prioritize it potentially. And lots of education and engagement opportunities. We're hopeful that we can speak to the GP VTS scheme soon, or 3 of them, 1 in each county. and that would be another engagement opportunity, because I think newer GPs are used to IT more than older GPs, and probably they're a good audience to start using this. So we ask everyone to just log on and have a look and get used to the system, to get involved if possible, if you've got a subject matter expertise as a GP with a special interest. You may wish to be on the review group. Every pathway goes out to a wider review nationally before it goes live, to allow everyone the chance to feedback. We ask that people promote health pathways when they can as the tool of choice, partly to reduce that variation, because we don't really want primary and secondary care doing different things. We would like to be involved with education, pathway development, and any engagement opportunities to just educate people that this exists. And we'd always want feedback of what's working and what's not. So we have got a few case studies with people that have been using the system. And importantly, evaluation. There is a national evaluation exercise going on at the moment to look at how health pathways has changed referral practice, hoping that it will streamline it. It may not reduce referrals, but it may get referrals to the correct place at the first time, rather than 3 referrals later. So these are just some quotes that we've had. So on the map, those are the areas which have got pathways live currently. I have to say, I'm not sure what's happening with Betsy and Powys at the moment. There may be people in the audience who know more than me, but we have been told that they are coming online at some point. So these are all good feedback. I suspect the people who aren't engaged with it aren't feeding back, so probably slightly biased. But there is a National Health Pathway Survey live. If anyone would like to scan that, who is a user, please feel free. And we're looking forward to the results of that. We did a survey within Hywel Dda at the start, and we've recently repeated it. So I think we've extended it because we didn't get too many responses. And this is just a reminder of what we're trying to avoid. This upsets me. My OCD goes mad if I see a wall like this. We don't really want bits of paper stuck everywhere with blue tack in clinical areas. So hopefully this one-stop shop, this resource of having everything in one place, will avoid this. And also really good for staff who work across boundaries, across counties, across health boards as well, just to know where everything is in one place. So there's time for questions. I'm going to come out of the presentation if I can, so you can see me and I can see you. Okay, right. Karen's putting something in the chat. Or if anyone would like to request a username or password, if you can click on the link and contact us, and Karen will send it to you. Yeah, what we've done in Hywel Dda, which is slightly different to the other health boards, is we've got not personalised logins, but logins by GP practice. So we can see which GP practices are utilising it. And we've also got a hospital login, a GP out of hours login, and a community login. So we know where it's been used most and where we need to engage with. Okay, no questions in the... Oh, there's a hand up. Hello. No, I think you might be on mute in the room. Hang on. Regita's, yeah.
So much. I'm with Uma.
Oh, hello.
Hello. Just to let anybody know, if you want to know anything else about community health pathways, and we think of a question later, we're assisting with the implementation, and we have a stand in the other room.
Oh,
so
fab.
If you need any more information or you need to be put in touch, you think of something later, just come and chat with us and we can put you.
Yeah, I meant to say, if there's any questions about Betsy and Powys, I was going to share Emma's contact details, because I really honestly don't know, but you probably do, in terms of timelines and what the hurdles are, etc.
I think Betsy is slightly further ahead. I'm not sure what's happening in Paris at the moment, but we've got some good news from Betsy.
Excellent.
But we're not sure. But we're a community services run from there, so yeah, it'd be good. It sounds really good.
Yeah, it's coming. We're trying.
Can I ask a quick question? Is it only open to medical staff, or could community nursing access it as well?
No, sorry, definitely, yes. Community nursing can access it and do, because we've been to our nursing forums and they're actually quite often more positive than the GPs who it was designed for. I think there's a lot of useful information on there. Our district nursing request page is especially complex, and I think that's really handy for people who are new to the area or work across counties, because I don't know how you'd ever know how to refer at different times of day, different days of the week, different clusters, different teams. So yeah, certainly open to community colleagues.
And how long did it take to implement?
So we started work officially in March 23, and we went live then with over 50 pathways in December 23. I'm hoping Karen will chip in if I'm wrong, but we needed at least 50 pathways live to get going. And those were 50 pathways that we in Hywel Dda wrote mostly from scratch, because apart from Cardiff, we were the next to go live. CTM have gone quite quickly, I think, because there was a lot of pathways live for them to start with, to localise. So they've done it slightly a different way round to us. So we went with designing them first, and they've localised first and are now working on some from scratch. So I think for people coming on board later, you could potentially do it quite quickly if you focused on the localisation more, because the pathways are there. It's just the localisable elements that need doing.
No questions are coming up. Could I just ask, so my name's Jane Spivey, I'm the Macmillan Cancer AHP lead from Powys Teaching Health Board, and I'm working with the Improving Cancer Journey to try and sort of integrate sort of local assets into such pathways, and obviously our priorities around cancer. And you mentioned it's good you're recognising there's patient programmes. Do you consider is social prescribing as part? Social prescribing considered as part of those pathways? Like, would you consider third sector organisations and signposting?
Yes,
patients as part of that resource.
Yes, and we've got a Macmillan cancer lead who's our support CE, Sarah Allen. You might know her, but she has been looking at some of these third sector bits and how we fit them in, and it's often quite difficult because they vary so much by cluster and they change quite a lot. So, and we were looking at one of the palliative care ones recently, and we couldn't really identify that much if it wasn't cancer, but if it was palliative for another reason. So yeah, so we definitely are considerate and sometimes struggling with finding the information, but where we can specify, we link to it. Where we can't specify, we definitely put a prompt to consider it.
Lovely, thank you.
Thank you.
It just gives me an idea, Nick, of how I could work with Powys when Powys get on board of this.
Yeah, identifying them's an issue. Yeah, so that's one of the jobs Sarah's been doing. She's got more awareness, especially because she's the team member who works in Ceredigion. The rest of us are in Carmarthenshire and Pembrokeshire.
And then what's Sarah's surname? She might be a good point of contact.
Allen, Sarah Allen. Yeah.
Thank you.
Right. I think we're out of time. So thanks everyone for your time and your engagement. And we're happy to be sent any questions afterwards if anyone thinks of anything. Thanks all.
Thank you.
Bye.
Hi everyone online. Can you hear me all right, Lauren?
Oh, yeah, I can hear you well.
Brilliant. We solved the echo, we think, so that's good.
We
So
can hear you.
You can't hear me?
We can hear you now.
Oh, you can. Excellent. Good. Thank you. So Brynhaldar, Croeso, good afternoon, welcome. My name is Natalie. I'm a GP academic fellow working for Swansea University, but also a GP working clinically in Tregaron, in North Ceredigion, and in GP out of hours as well. And on screen is my colleague Lauren as well, Lauren Blake, who sadly couldn't come down today, but works at Swansea University as director of the RHYME scheme, which I'm going to tell you about. And before I do, I'll just tell you a little bit about my background, just that I'm from the southeast in Surrey originally and went to medical school in London, and came and did one of my placements having absolutely no connection to Wales at all. I don't think I've ever been to Wales. Did one of my placements in medical school here and basically haven't looked back since, and came for my GP training and will not leave unless you make me. So I'm really passionate about exposing a range of medical students and other healthcare professional students to Wales, and particularly rural Wales, because I think if you haven't seen it, you haven't experienced it, then how do you know it's not for you, is my position. You may have seen me give this, or someone may have seen me give this talk before, back in March, which is when we just done the placement I'm going to tell you about. And I pitched it as kind of growing rural doctors or growing rural healthcare professionals, planting the seed. And since then, we've conducted some formal research on what we did, which is what I'm going to go through today. Oh, there's a bit of shuffling in the background. Can we mute? Is that all right to mute?
Yeah.
Thank you. So what I'm going to run through, so why we did what we did, who, what, so what, now what. RHYME is, so Swansea University has a purely graduate entry medical track. So it's a 4-year degree, at which point they graduate as doctors, go off to do their foundation programme anywhere in the UK. Within GEM, Graduate Entry Medicine, we've got the Rural and Remote Health and Medical Education track, the RHYME track, which is a track that the students can choose to sign up to for the duration of their 4 years. It doesn't involve much in the way of extra work, but it means that they get allocated to more rural placements. They need to put a rural focus on some of their assignments. So it's encouraging them to be looking at their training through that lens. And it's RHYME that Lauren is the director of. So why? You don't need me to tell you about the recruitment and retention issues in rural or healthcare generally, but in rural healthcare. You'll be very aware of the Save Our Surgeries campaign that Dr. Sue Fish here was very involved in, for the BMA Cymru 2023. And this, reading this, and you can see the sort of statistics over the increase in patient demand, the decrease in number of practices, a decrease in full-time GP equivalents. So you get the picture of increased workload, reducing resources. And this was a schematic for a couple of years ago that shows the number of practices closing or going to the health board, things like that. So it's an increasing issue. In Save Our Surgeries, there's issues around retention, which we're not going to focus on today. This is more about recruitment, but obviously is another important area. And when it comes to recruitment, so Wales, this really shocked me. Wales need 664 more GPs, not even accounting for less than full time, to have the equivalent GP to patient ratio compared to the EU. That's shocking, right? So we need to get more doctors. Now, the Medical Schools Council have proposed in 2021, 5,000 more medical students in the UK. Brilliant, great, that's steps towards getting the more doctors. And there are lots of fantastic widening participation initiatives, increasing, getting these students in. But where are we going to put them? Rural placements is the answer. Why? Okay, so why? There's a lot of evidence base around rural placements. The fact that they work, students perform as well clinically, if not better, than the equivalent urban placements. And the undergraduate exposure impacts on career choice. And particularly this paper assessed the 3 main factors most strongly associated with choosing a rural health career. And one of them is positive clinical and educational experiences in rural settings as part of undergraduate medical education, with the other 2 factors being a rural upbringing or having targeted training in rural healthcare as a topic. So that's why. Who? So what we did was the issues were all around logistics. How do we get these students that are interested in rural health up to somewhere like Aberystwyth or out of Swansea to deliver rural healthcare based activities? And without much in the way of funding or logistics, we decided the best way we could do it was hijack the existing placement structure. So in the first year of the course, there's one mandatory clinical placement that's 5 weeks, and there were 13 places for that already based in Aberystwyth. So we said, great, let's get our RHIME students allocated to those 13 places all together for 5 weeks, and we can do some stuff with them. Didn't have control over the time of year, January, February, not the best time to show off Aberystwyth, but we did pretty well. So we piloted this in January and February of this year. So the cohort have now gone into their second year. We had 26 applications for it as a pilot initiative, and for the 13 places. 12 participated in the research. So 7 of those 12 had a rural background. So quite an even split between those that had a rural background and those that didn't. And that was out of a first year cohort of 156. So we thought 26 applications for something new out of 156 was pretty good. So it showed that the interest was there. So as I said, 5-week mandatory placement. Most of them were in hospital in Bronglais and secondary care placements. Some were in what's called CBL, which is a GP-based placement. And it was middle of Jan to middle of Feb of this year. What do we do? So as you can see, the weather behaved for me on the first day. We did a lovely walk around Aberystwyth, an orientation tour, where I showed them kind of, good places to eat, walked along the prom. So it was just a kind of orientation and chat. I didn't take any photos, but the second thing we did was at Bronglais in the education centre. We brought together the GP trainees in the local Aberystwyth GP training programme with the medical students, and we did an afternoon of joint training, getting the medical students to be actors for the GP trainees, but it also gave them the chance to connect and network and chat. We then this was just a social thing, so they were totally up for going for a hike on the weekend. So we did Borth to Aberystwyth, 7-mile hike along the Welsh Coast Path. You can see standing on the bridge on the top right is my husband, and my mum's at the back. So it was a proper family affair. Mum brought flapjacks, which was great. So that was just kind of, again, social and showing that aspect of life outside of clinical work. We went down to the RNLI station with Ian, who's a paramedic who works locally and works the RNLI as a medic and a helm. And he did a tour of the lifeboat station. Lauren won the race for putting on the kit the quickest. So you can see she's very pleased with herself there. And they got to have a little look at the boat and play with some of the kits. We then on a different day went down to Aberystwyth Fire Station, and we did an interactive day of predominantly RTC, so road traffic collision exercises. There were a couple of paramedics present as well, so a bit of interprofessional training. And the students were largely observational for this because, my risk assessments couldn't handle any more than that. As you can see, very sort of present in the action, firefighters talking them through what was going on, and getting to see some of the challenges of sort of rural pre-hospital care and sort of rural response times and the impact that can have in where we live. We then went up to, where did we go? We went up to Gwynedd, up to Cregennyn Lakes to meet the South Snowdonia and Abu Dhabi mountain rescue teams, where we did a mass casualty scenario. So the students were acting as various DFE groups who've got lost all over the mountains. I ended up last minute being the DFE teacher who'd lost her students, which I could totally relate to, and ended up breaking my pelvis, all not for real, and being stretchered down the mountain. As they can see, that's me in the middle there. So that was unexpected, but very fun. And then finally, where I work as an out-of-hours doctor in Bronglais, quite a lot of the students volunteered to come and do a shift with me out of hours, one-to-one, getting to see rural GP in the community out of hours. And I also did a little workshop with them on rural community care that one of the Powys district nurses and one of the Powys palliative care nurses joined online as well to chat with them about rural healthcare from their point of view. So quite a range of experiences, and it was really important to us that there was a balance between primary care, GP, community care, and sort of pre-hospital exciting flashy stuff. And I think it's the pre-hospital that what got the students excited, but actually the primary care, community care that they really connected to and probably got more from actually. So that was really interesting. So Lauren and I have then done a formal research project to evaluate this. The aims of the placement were to provide an immersive experience in a currently undersubscribed rural location, to improve understanding of the benefits and challenges of living and working rurally, and to ignite an aspiration to live and work rurally once qualified. And the research was intending to evaluate the success of this using the research questions. How does this placement impact students' perceptions of living and working rurally as a doctor and their future career aspirations? And this was a pilot project. Oh, sorry, research questions. There we go. This was a pilot project which we're continuing over the next couple of academic years. We also found that this increases students' interest in future placements and also other things about the benefits of the trainers and the students, having this bunch of like self-selected, enthusiastic students who were there by choice, not because they drawn the short straw, we got really a lot of positive feedback from the administrative and the placement providers, so the GPs and people providing the placements, about actually, the positivity of having this initiative. And also the fact that it was just this whole placement package just created this whole buzz, and like everyone was like, ooh, Aberystwyth. There's this whole kind of ripple effect of this buzz, which was really great. And that kind of, Lauren was feeling that at the university as well, which is really nice. So there was this kind of buzz effect and bonding amongst the group. So I'll just run through quickly with our methods. So we had 12 of the 13 were happy to engage with research, so pretty decent response rate, varied backgrounds, quite a lot rural, but not all in the UK. As you can see, we had some Australian and American students. We did some focus. So Lauren led the interviews to give the students know how much I care about Aberystwyth. So we felt it would be more valid research if Lauren led the interviews than me. And she was able to offer them in English and Cymraeg. And then they were anonymised before they were handed to me to analyse, which I did using coding in NVivo and a basic thematic analysis. We also collected some mixed methods questionnaire data. We weren't in a position to do statistical analysis of that, the sample sizes and things, but it was there to just corroborate and triangulate what we were finding. And we had ethical approval. So I'm going to run through now what the themes were that came out of this. And I'm going to put a quote up. Well, this is just a general quote first, and then I'll go through each theme with a quote, and I'll just be talking through that theme. So this was just one of the main quotes that came out that I think is really nice. This was an excellent experience to have as my first placement. I genuinely enjoyed the supplemental activities outside of clinical life and bronchitis. They demonstrated the unique aspects and challenges of rural life and medicine while providing an excuse to explore the landscape of Ceredigion. This was likely the best means to recruit physicians to work in areas like Aberystwyth. And this particular student was somebody who was very much, I'm going to be running a trauma centre in a big, urban centre from an urban background. So I think it was really powerful that this was experiencing. So the first theme that came out is community. Within the first couple of weeks, we knew our neighbours and our neighbours knew our faces, and kind of people that had seen the GP would wave to me on the street. You come back to the city and you don't have that same, even in a small one like Swansea, you don't have that same community. So there was a lot of stuff that came out around the positive impact of interactions with colleagues, patient and the public, getting involved. Quite a few of the students got involved in local sports groups and things, and they were there because they felt able to do that. And there was this quote that came out quite a lot of everyone knows everyone. Observing effective teamwork and camaraderie, particularly when they saw the different teams or some of the exercises we did working together. Everyone, oh, hey, mate, how you doing? Yeah, nice to see you. That sense of community around them, as well as being incorporated into that team and community in the time that they were there, the short time they were there. Also then the bonding within the group, so the 13 of them, they'd all go around to each other's and make dinner and, revise together. And it's that real sense of bonding from having this kind of packaged experience. The educational experience. There's always this idea that you want to go to the biggest hospital so you can see the most coolest cases and stuff. But in rural areas, you're more of a generalist, like you can do more things and like help more people. So the idea that they very much felt that the placement, it is what you make it. So they were all very passionate, enthusiastic, got stuck in. Lots of positive feedback on the additional activities we provided for them, as well as their actual placement experience that they were doing, same as they would have done normally. So getting involved on the placement. They felt that they got the chance to be involved on placement, got the chance to do things, and that they generally had very supportive educators, which improved their experience. And getting that input from friendly local clinicians made them feel a lot more connected than when they're one of 8 students standing on a ward in a bigger hospital where no one really knows their name or they feel that particularly cares about them. So feeling like they're cared for, looked after, was really valuable. This I think is really interesting. So this did come from the questionnaire data, and this is what I was saying about from the educational point of view. Which activity did you enjoy the most? They love the fire and rescue, the mountain rescue. It's fun, it's exciting. They get to play acts, terrible injuries. But actually, what did they learn the most from? The predominant, their 3/4 there was from the GP focused learning. So we really felt that in the interview data as well, that although they really enjoyed the exciting stuff, they really felt they could relate to the GP trainees, which I'm going to come on to in a minute. So the next theme was understanding the strengths and the challenges of the area. And this included Welsh language. So we had a few of the students were Welsh language speakers. And as you can see, in Aberystwyth, the Welsh language is used much more than Swansea in my experience. I was so happy to be able to speak Welsh with people up there. I could help the doctors and stuff with that. I was really proud to be able to speak Welsh. So a lot of our Welsh speaking students really felt that they got the chance to engage that day to day in their placement. So as well as that, providing holistic care through continuity of care, understanding the patient's needs, treating them in their own environment. And the students talked about providing basically the same medicine, but in a rural context and how that translated. The rural challenge, so dealing with emergencies, dealing with challenging terrain, like when we were up in the mountains, completely different experience. The lack of service availability or the significant distances they were seeing the patients having to travel for healthcare. And quite a few of them were really affected by the impact of the health inequality that they were seeing compared to the urban environments. The rural doctor is a role model. You can still, achieve everything you want to do living in a rural area. So I feel like it's kind of reinforcing that there'd be less boundaries. Like I wouldn't be setting myself any boundaries by living in a rural area. So I think some of them had the idea that, rural GPs are GPs that are just not quite good enough to be in the city. And actually this, what came through on this theme was that they were really surprised by the actual broader scope and skill set of the rural clinicians that they were acting with, that they were working with, seeing how they were carrying increased clinical responsibility, decision-making and managing risk across large areas. Often as an out-of-hours GP, I'll be covering the entirety of Ceredigion or North Ceredigion on my own. So seeing how we manage that. Meeting a variety of clinicians from different backgrounds and different training journeys is really good as well. They're not all going to relate to me, but they met through the GP trainees, other people that they could relate to. And they had particularly had high levels of relatability among the GP trainees. And the afternoon they spent with the GP trainees was really valuable because what a lot of them said was the learning they're doing is just like the learning we do at medical school. Like they're learning similar things in similar ways. And a lot of them said, I can see myself doing that. So it was that sense of actually, I can picture this as my future. Also experiencing enthusiasm again of clinicians they met across the different professions and different activities that we did, and the general sort of clinical variety and different things they could see. Lifestyle. It showed me the possibilities of if I go into this career, I can have this kind of life outside of it, and that kind of life outside of it really fits me nicely. So many, I forgot to say, by the way, all these pictures are just my pictures from life in Aberystwyth. I should have said that at the beginning. Couldn't resist an opportunity to show off the area. So a positive experience, that's actually Borth Beach, isn't it, Sue? So yeah, positive experience of rural work-life balance, the ready availability of the scenery, outdoors activities. Many of them were passionate of being in the outdoors and really noticed that when it's on their doorstep, they could engage with it in a way that in reality in a city, there might be a park, there might be the sea. Swansea has the sea, but how often do they actually go down to it? Whereas in Aberystwyth, they were living near the seafront. They got the opportunity to go down every day. One of them mentioned in her interview, she was doing her 5K run along the prom every day. So really engaging with the scenery and other social activities. They're really happy with the town, relaxed, clean, safe. It had all the things they felt they needed, which was surprising to some of them. Benefit of Aberystwyth as well was that it's got quite compact geography. Even those that didn't have a car felt able to manage, although there was some mention that it was potentially a little bit isolating, particularly if you didn't have a car in terms of getting out of the town. And they did really value actually the orientation walk, which I sort of just did because I thought it'd be nice. And actually there was a lot of positive feedback about that sense of grounding them right at the beginning on their first day of where they are, where they can go from a social point of view, as well as just understanding the logistics of there's the bank and it doesn't open anymore, but there it is. Cool. Impact on aspirations. So this placement confirmed what I want to do, which is working in these kind of rural areas, but also make sure that I'm well equipped, going there with the full intention to set up a really good service or make sure that something's provided there that the people really need. And then I've put on this second quote. This has made me think the complete opposite now, that I would rather work in like a smaller rural location. And I've put these two up because I think, again, there was a divide between those that came on the placement knowing that they love rural healthcare, knowing that it's what they want to do, and those that had never intended to work rurally but thought the placement seemed like quite good fun. And actually, the feedback from all of them is positive. Those that had wanted to do rural health hadn't been put off, and those who hadn't thought about it before as an option were like, oh, actually, yeah, this could be a goer. So many of them are very committed to exploring Wales during their degree and felt that getting out early on in their degree was important. Yeah, as I said, for some of them it's preaching to the converted, and others it's increased the appeal. None of them reported feeling negatively towards having a rural career in the future, and hopefully that's not a research bias. And also then, as we mentioned earlier, the additional kind of ripple effect of the fact that now we've got other students asking, saying, I want to come to Aberystwyth, when can I go? So that broader sense. And also that sense of, and this didn't kind of come up in the data as such, but I definitely felt that the students on the placement had that sense of, as you get, of that kudos of having been selected for the placement. So that was a positive reinforcing thing as well, that made them feel like they were fortunate to be there, rather than, as I said, having drawn the short straw. So what? So in terms of limitations of the research, so it was self-selecting group of participants, and they'd never experienced a clinical placement before, and we weren't able to establish a control group. So some of the positive feedback we were getting was because it was their first time being out on a placement, and it was better than sitting in a lecture theatre, rather than necessarily being relevant to the rural versus urban. And the sustainability, loads of enthusiasm and buzz immediately afterwards, but maybe now, almost coming up for a year later, it's like, oh yeah, but will they come back? We don't know, and that's something we want to look at in the longer term. So our conclusions: creating an exclusive placement package incorporating additional rural health activities, particularly with a pre-hospital focus, is attractive to medical students. There's no doubt of that. We've just done applications for this coming year. And we had, I think it was about 35 applications for the 11 places for this year. So again, the interest is there. Immersing in the local community and experiencing the benefits of a rural lifestyle provides a positive personal experience. Educational experience is improved by having supportive educators and students getting involved. Structured activities that promote group bonding and orient to a new environment are beneficial. The rural doctor is perceived as having a wide professional skill set and understands the needs of their patients and the challenges of their area. GP-oriented activities promote learning and provide opportunity for medical students to relate to GP trainees. And early exposure to a rural environment may increase the desire to return to rural areas for future placements and/or training. So now what? So we're doing the same thing again this January, February. We're also expanding into Pembrokeshire. So we're delivering the Pembrokeshire experience to second year students. They're the ones that applied for ABBA last year in April, May, and that's got a bit more of a coastal medicine focus. So we've had an amazing response from PEMS clinicians. Turns out they're as passionate about Pembrokeshire as I am about Aberystwyth, which is great to see. So even though it's more of a challenge because neither Lauren or I are based clinically in Pembrokeshire, but we've been able to link in and build up that network to hopefully bring this together. We're going to do a full research evaluation again of these. So this is just the pilot, and then we'll be bringing that data together, and then hopefully beyond in future years. What are our barriers? Placement capacity and logistics, as I'm sure you'll understand. Trying to get the right people in the right place at the right time, ticking all the right boxes, is surprisingly difficult. Workforce and resources. We've done all of this with no extra funding. It's all been through my role as an academic fellow. And having the local knowledge and the contacts, again, is a challenge. Availability of experiences is actually less of an issue than I thought it would be, but potentially could be in a longer term sustainable point of view, and raising awareness, which is why I'm here. So in summary, my takeaway messages are that early exposure is really important. Here are our key themes: so community, lifestyle, the educational experience, the rural doctor as a role model, understanding the area, and that we hope will lead to impacts on aspirations, if not at least just understanding of what a rural healthcare career looks like. And there are mine and Lauren's email addresses. If anyone wants to get in touch, please do. And our references there. I will leave that on screen in case anyone wants to make a note, and happy to take questions. And again, Lauren on screen as well if anyone wants to ask anything. Yes, hello.
I think that's really interesting and very positive. And on the side, I wonder what it would be like in Paris, which is known as the Green Desert. You haven't quite got that sort of coastal, exciting environment. But your comment about the skill set and the competencies. In Czechoslovakia, they've got a project called Go Rural, and it's a small pilot and it's being rolled out. But the messages come back from there and other countries. I think it's probably true here. The messages you get in your urban medical school, if you're any good, you really need to go into a big teaching hospital and do research and teaching. How do you overcome that? I think that's really good, and you don't want to lose those messages, but it's a long way until they finish and they do their foundation years. Somehow we need to overcome those messages from that centralised urban medical school.
Completely agree with you. So yes, if anyone can hear that online, just around messages coming out of, where was it? Czech Republic, around this belief from students that this message from urban environments that if you're any good, you'll end up in the urban environment. You'll compete. They compete, don't they? They compete for the urban environments. They have to get their PhDs and things like that. Whereas actually, I would argue that if you're that good, then you can cope with a rural environment, which is
that message.
And I think for this, it was really important for them to see, and again, particularly myself being not from Wales, not from a rural environment at all, it's showing them that, that it is an option, and just expose. I think just exposure, getting exposure. They've got to see it. They've got to experience it. Thank you.
The rural student group. To build on and take it forward.
And we do have, so there's there's a rhyme society now, so or like the students, we've got rhyme student reps and things like that, so getting the students more actively involved with it. And with your comment about Powys, it's really interesting you say that, because Powys was quite high up on our, we want to do the Powys experience, but we didn't have the placement infrastructure. So we didn't have enough students in a remotely commutable place at the same time to be able to make that happen yet. But it is something that we definitely would like to explore in the future.
We used to again on previously.
It's more having, there are some students that go on GP placements for that 5-week placement in Powys, but not many, and they're very disparate. So we had to use Aberystwyth, and now with the because you've got secondary care as well as the GP, you've got enough of them in a similar place at the same time to actually pull it together, which we haven't got in Powys at the moment, but we'd like to expand that. Yeah, please do. Any other questions in the room?